So hello everyone. Here we come up with the latest pulmonary embolism guidelines, 2026 clinical practice guidelines for the evaluation and management of acute pulmonary embolism in adults. These are jointly issued by AHA, American Heart Association, and American College of Cardiology, along with the multiple society consignatories. So let's quickly dive what has actually changed in these guidelines and what is updated. So coming to the risk stratification, so the core principles of using the history physical examination as well as the scores for clinical probability scoring, including Wells, modified Wells, Geneva, modified Geneva, they all remain same as previous. D-dimer age adjusted has to be used just as similar. Biomarkers including troponin and BNP remains the same, and RV dysfunction on echo as a criteria for the higher risk remains the same. So this is one of the table. There is nothing new in it. COR stands for class of recommendation and level of evidence is ABC. B is further they have classified into R, NR. R is randomized, NR is non-randomized trial. And then they have limited data, LD, and expert opinion, EO. So again, history and comprehensive physical examination has to be done. And of course, in patients who have low to intermediate clinical probability of PE, you have to check for age adjusted D dimer, that is age into 10. Also, they focused upon Ear's algorithm, which says that if your D dimer is more than 500 plus any one of the following, including DVT, clinical signs, hemopsis, and or PE as the most likely diagnosis, can be used as Ear's algorithm. But if you have directly D dimer more than 1000 microgram per liter, then there is no need for any other further criteria. So the Ear's algorithm can be used to justify whether further imaging is needed or not. So this is one of the table or flow chart showing the clinical evaluation of patients with suspected acute pulmonary embolism. This is almost same as previous. So again, starting with history and physical, clinical probability scoring, which classifies into low clinical probability, intermediate, and high. Low is less than 15%. Intermediate is 15 to 50 and more than 50 is high. So of course more than 50 there is no dilemma, you have to anyhow go for the further diagnostic imaging CTPA. In clinical low probability you check for PERT criteria, pulmonary embolism rule out criteria. If all the criterias are met, then definitely PE is ruled out and you need not to do further imaging. But if there is any no in this side or there is intermediate clinical probability, then of course you can do D-dimer and Ear's algorithm, and based on these two you can further decide whether PE diagnosis is excluded or you need to perform the diagnostic imaging. So what is the major change that has happened and that everyone must know is the replacement of the older terminology. So earlier you have massive PE, submassive PE and low risk PE, but now it has categorized into A, B, C, D, E, and this integrate all the data including clinical severity scoring, hemodynamics, respiratory status, biomarkers, RV dysfunction. So this is important because now they move from a binary hemodynamic classification to a granular approach, and this will of course help in telling the prognosis, treatment selection as well as escalation timing. So this was 2011 classification of pulmonary embolism, which classified it as low risk, submassive, and massive. Then this is 2019, which changed submassive into intermediate low risk and intermediate high risk. But now we have this ABCDE classification of 2026. We'll consider and deal with each class A, B, C, D, and E in further slides.
So let's start with A. So A is subclinical, incidental, and asymptomatic.
So basically, it is the least severe category which actually focuses on the asymptomatic and incidentally diagnosed PE. So for an example, what they have given in guidelines is category A1, it means an acute PE which is incidentally diagnosed. A patient of lung cancer came for a CT chest for staging and incidentally found to have a left lower lobe subsegmental PE. Then coming to B. So B is symptomatic, low clinical severity scoring. The severity scoring based on PESI score, simplified PESI score and HESTIA scoring. So it is further classified into B1 and B2, where B1 stands for single or multiple subsegmental, whereas B2 includes patient with a segmental and more proximal pulmonary embolism. And the intent for distinguishing these two is basically with how to triage the patient, whether you want to give patient a home treatment or a hospital treatment. And also, depending upon the location of the acute PE, the decision to anticoagulate may also differ. Also, the presence of DVT, concomitant DVT, can also change the decision of anticoagulation. So they have given one of the example of category B2. So what they say, a patient who presented with the uh, pleuritic pain after hip replacement, but all the scores like PESI less than equal to 85, simplified PESI less than 1, HESTIA less than 1, but he is found to have a right lower lobe pulmonary embolism and there is no RB enlargement on CT. This comes as category B2. Then coming to category C. So C is symptomatic and the chances of adverse effects here are more. So the clinical severity score, that is PESI, simplified PESI and HESTIA, are comparatively high. One of the R parameter which is added here uh, is basically when the patient needs oxygen in form of nasal cannula, face mask or anything like that, and it is further classified into C1, C2, C3 based upon echo and blood findings. So if both biomarkers and echo has no RV dysfunction, then it is C1. If either of them is abnormal, it is C2, and if both of them are abnormal, it is C3. So basically this subcategorization allows for recognition of absence or presence of cardiopulmonary dysfunction. So this R is applied when there is hypoxemia or tachypnea and need of supplemental oxygen. So they have given an example of C1R. So a patient of breast cancer coming with dyspnea, tachycardia and hypoxemia and bilateral lobar pulmonary embolism, but actually there is no abnormality on echo and all the biomarkers including troponin and proBNP are normal, comes as C1R. So coming to category D, which says incipient cardiopulmonary failure. So basically it focuses on pre-cardiopulmonary failure states like a normotensive shock or patient might need ventilatory support in future. So it is further categorized as D1 and D2. So D1, patient is having a transient or recurrent hypotension, but this hypotension is transient, short-lived, and it responds very well to the volume expansion. And also there are no signs of reduced perfusion or end organ dysfunction. Whereas in D2, patient is having marked decreased perfusion, end organ dysfunction in the form of low urine output, elevated lactate, and there could be transient hypotension. Also, respiratory modifier criteria is also to be added if patient is needing more than 6 liter of oxygen or patient is needing an RPM mask. So they have given an example of category D2, a patient who recently had a spine surgery, developed sudden onset dyspnea, tachycardia, hypoxemia, but having a normal BP found to have both right and left pulmonary artery embolism. But there is increasing creatinine, patient has low MAP and are to be added according to the oxygen requirement. Then coming over to E. So E basically the patient has landed up in the cardiopulmonary failure. It is further categorized as E1 and E2. E1 is the patient having recurrent or persistent hypotension along with cardiogenic shock. E2 is refractory cardiogenic shock or cardiac arrest and patient is not restored back. There is no restoration of spontaneous circulation even after 30 minutes of CPR. And here the respiratory modifier criteria is to be involved if the patient is having need of some form of ventilation, either non-invasive or invasive. So what actually changed? There is a shift from this massive, submassive, and limited to A to E categorization. Basically, now we are doing resource optimization. So in the emergency department itself, you can triage the patient and reduce unnecessarily admissions. So category A, if the patient is asymptomatic, you can discharge from emergency department itself. And category B patient, even if they are symptomatic, but you know they have very low severity, so they can be planned to discharge early. In the older guidelines, as such, there was no discussion, no structured performa or availability of formal discharge categorization. Coming to the diagnostic, still CTPA remains the gold standard. Still the indication of VQ remains reserved for the special population like high creatinine, obese people, anaphylaxis to the contrast. Of course, hemodynamic instability criteria remains same, and presence of hemodynamic instability makes the patient high risk pulmonary embolism. Persistent hypotension, you have to act aggressively. Coming to the treatment part, this remains the same. The initial treatment phase, which is first 3 to 6 months of anticoagulation therapy, and extended treatment phase, which is beyond 6 months. Coming to this treatment part, or maybe summarization of all the categories. So we'll focus on the treatment part only. So in category A and B, if you are sending patient back to the home, DOAC are the preferred group of choice. So direct to oral anticoagulants, they are the preferred group of choice. Where you need a patient to give parenteral anticoagulation therapy, they have told to initiate LMWH. And of course, in the E2 category, there you can decide either LMWH or UFH depending. This is one thing. Criteria remains the same. This we have already discussed. Patient in E2 category might need veno-arterial ECMO. Again, apart from this, they have further discussed about PERT, pulmonary embolism resuscitation treatment assessment to guide the clinical management. Vasopressors and inotropic therapy might be needed in the D2 and E categories. Coming to the thrombolysis, so thrombolysis part, then mechanical thrombectomy part, and then catheter directed removal. All this, they are to be done in category D1, D2, even E2, but then in selected cases, if you have acceptable bleeding risk, this has to be seen. So now what they say that LMWH is preferred over unfractionated heparin. So in terms, if you need parenteral anticoagulation, usually from class C, so LMWH can be given safely and is preferred over UFH, whereas the earlier guidelines used to say that LMWH has to be given if there is a stable PE and UFH to be given if patient is hemodynamically unstable and hospitalized. But now, since we have a predictable pharmacokinetics of LMWH, we have lower heparin-induced thrombocytopenia risk and reduced monitoring is needed. So LMWH is fairly a good gold standard or maybe used in patient beyond category C. Then coming over to the warfarin and DOACs. So of course, DOACs are now the clear preferred choice over the VKA unless and until contraindicated. In 2011 guidelines, if you see, so warfarin was still central, and somehow in 2019 DOAC came into the scenario, and now they are the preferred. So now let's discuss few condition where LMWH, unfractionated heparin, warfarin, these are recommended over DOAC. So of course, breastfeeding and pregnancy, because they don't have much data on DOAC in these conditions. So of course, you have to give safer one LMWH, UFH. Warfarin accordingly, which trimester is ongoing, because you can't give it in the initial trimester because of fetal side effects. Then coming over to the condition where DOAC is preferred over warfarin. So of course, in chronic liver disease, in childhood stage A and B, C, they don't have much data. Primary or metastatic brain tumor, of course. In CKD, you can give in stage 2 to 3 mild to moderate CKD, but also in 4 to 5, what they say is if you have confirmed PE patient is on end stage kidney disease, on dialysis, and need oral anticoagulant therapy, they say it is uncertain whether apixaben is better than warfarin to reduce major bleeding. They have not said an absolute contraindication. It's a clinician-based decision. Coming to concurrent therapeutic anticoagulation, acute PE patient who have undergone an endovascular procedure or just received thrombolytic therapy, what they say that in these conditions, Clexane or UFH or subtherapeutic anticoagulation with UFH is recommended over giving no anticoagulation, and of course LMWH is preferred over UFH. So overall, what we can say is they have given more preferences to DOAC and LMWH, and they have tried to reserve few conditions where you have to give this warfarin and UFH. So monitoring LMWH is when needed. So of course everyone know you have to measure NT10A levels and 3 to 5 hours after giving the LMWH dose. Once a steady state is reached and that state is received uh, after at least 3 doses. So you send NT-TNA level after third dose has been given for 3 to 5 hours. Then of course in severe CKD patient you have to give. Pregnant patients you have to check for NT-TNA level. Coming to the APLA syndrome, so thrombotic antiphospholipid antibody syndrome, warfarin is recommended in these patients. But one thing they have added that acute PE patient with only a single anticardiolipin antibody or a beta 2 glycoprotein antibody, they say in this condition, DOAC might be a reasonable alternative. Then there has been more focus on the PERT teams. So pulmonary embolism response team is recommended to improve the timeliness. This concept was not at all there in 2011, came a little bit in 2019. So these are all the advantages of this pulmonary embolism response team. So it improved risk stratification, it diverse insights from various specialists, selection and appropriate use of various advanced therapy, evidence-based protocols and pathways, educating peers and trainees, foster pathways for appropriate follow-up care, and further navigating the gaps in the evidence. So, who all are a part of PERT team? So, even the patient and the family members, the vascular medicine, pulmonologist or critical care, cardiac surgery, non-intervention cardiology, intervention radiology, plain radiology, vascular surgery, intervention cardiology, hemat-oncology, emergency medicine, nursing, pharmacy. There is a big thing. So, this model and process of PERT activation and when a PE is diagnosed, the designated in-house PERT physician is paged, the pertinent clinical information is gathered, and the severity of the case is assessed. If necessary, members of a multidisciplinary team, which we just discussed, they can discuss the case via the phone or virtual meeting or in person. Diagnostic and treatment options are discussed, recommendations are generated, appropriate resources are mobilized, and upon discharge, again, patient follow-up in this multidisciplinary clinic. So have they have given a PERT activation example in each of the category. So advanced therapies, they are more structured now. They have given more data, more trials. One of the trial was peerless trial where they have compared large bore mechanical thrombectomy with the catheter directed thrombolysis for the treatment of this intermediate risk pulmonary embolism. So much of the data has been embedded in this severity algorithm. They include in the advanced therapies mechanical thrombectomy, catheter directed thrombolysis, surgical embolectomy, ECMO, and of course, category E1. It is fairly enough reasonable to give the advanced therapy, give a thought over advanced therapy. In D1 to D2, you can consider about advanced therapy. So these are the category of recommendation and level of evidence. What says that in patient with acute PE in category C3 E2 from C3 to E2
who have an evidence of free floating right atrial or RV clot in transit. Here you can use advanced therapy over anticoagulation alone in order to reduce the risk of clinical deterioration. And then also in patients C2 to D2, and they have no contraindication for thrombolysis, and advanced therapy is can be considered either catheter directed thrombolysis or mechanical thrombectomy. Then systemic thrombolysis in high risk PE remains same. We have already discussed. So it is recommended if the patient is in shock, hypertension, and bleeding risk still the major limitation, no major reversal instant. Extended anticoagulation in unprovoked PE remains same. 3 to 6 months is minimum. Extended phase has to be given if there is unprovoked or persistent risk factor. This concept remains consistent. Coming to the pregnancy, now the pregnancy adapted years algorithm has been endorsed. So what they say, there is a strong imaging pathway clarity. They say that a low dose perfusion only lung scanning or a low dose CTPA protocols. These are the new things which appear effective and safe in experienced setting for the exclusion of PE in pregnant patients. So of course you have to get a D-dimer done. You have to check for the years algorithm. If patient comes that it needs further imaging, you can go for this low dose perfusion only scanning or low dose CTPA. Of course, they have mandated that in imaging reporting, now they have standardized that you have to write the numeric value of RV LV ratio on CTPA, and they have also standardized some echo RV parameters. So this is the table which says the numeric right ventricular to left ventricular ratio, which is measured by internal diameter assessed on the axial and reformatted 4D chamber view, has to be written. Also, they say on echo you have to comment upon RV by LV end diastolic ratio, TAPSE, RV free wall hypokinesia, McConnell sign, tricuspid systolic velocity. All these things you have to comment upon in echo. And also in patient with acute PE, then reporting of chronic features on CTPA so that we can identify the patient who are at risk of chronic clinical sequelae of pulmonary embolism, including the post pulmonary embolism, CTE pulmonary disease. Then they have given more focus on the post pulmonary embolism surveillance. It has been emphasized. So what they say now that you have to screen for chronic thromboembolic pulmonary disease symptoms at every visit for 1 year, and they tell to recognize post PE syndrome. So patient who have had acute PE should be asked about PE related symptoms, about the exercise limitation, functional limitation, breathlessness at every visit for at least 1 year to screen for CTEPD or other causes of dyspnea and functional limitation. So thank you all. This was all about the newer updates in the pulmonary embolism guidelines. Feel free for any query. You can directly DM me in the comment section. And please like, share, and subscribe if you want to remain updated in the pulmonary medicine field. Thank you.